Topic is principles of cervical alignment and the sagittal balance. We have performed lots of cervical spine surgeries, and some of the patients were very good after the surgery, and some of them were complaining about their neck pain. Like in this case, we have removed this tumor here, we decompress the spine, then we stabilize it. As you see, the screws are in proper places, but the patient was complaining about neck pain. At that time, according to our knowledge, we couldn't solve it. Then I saw a presentation on open operating theater. Please note that website endorsed by European Spine Journal. I saw a presentation there, and it was presented by Daniel Ryu there, and he is now with us. And this presentation changed lots of things. The aim of our surgery is decompress the spine, to stabilize the spine, and also to realign the spine. As Dr. Kaptanoğlu has told us, sagittal balance is important. The spinopelvic parameters are important. We know the relationship between pelvic incidence and lumbar lordosis. We know the importance of this SVA and its relation between the health-related quality of life factors. And we know the spinopelvic harmony and the importance of it. So we have to think that if there is a relationship at the cervical spine here, first of all, we have to know that if there is a proper optimal cervical alignment. In this study, they are talking about asymptomatic patients, and they say that the patient may have a large lordosis or a small lordosis, or maybe kyphosis, and in some patients maybe kyphosis and also lordosis. We know that all parts of the spine is related to each other, and when we are operating a patient, we start a domino effect. And also we know that the cervical spine is an adaptive segment to the global alignment. In this patient, if you look closely, if you operate the lumbar area, you may correct the thoracal area, and also you may change the cervical area. The preoperative and postoperative lordosis of the case. In this case, we have overcorrected this patient, and the patient was having a normal lordosis, but after the surgery, because of the overcorrection of the thoracal area, this patient come too much back, so the patient tries to bring his head over the pelvis, and he created a kyphosis at the cervical area. And these two patients, one of them has 21 degrees lordosis and the other one has 6 degrees lordosis. But they are not different patients, they are the same patients, with only operating this patient at the lumbar area to restore the lordosis. You change the thoracal area, and also you change the cervical area. Another case, an ankylosing spondylitis case, this patient has a horizontal gaze problem. You may think that to achieve this horizontal gaze problem, you may change the cervical area, but you don't need that. If you only perform a pedicle substruction osteotomy at the lumbar area, you may achieve the horizontal gaze problem. Another case presentation, this patient has had a Chiari surgery, and after that this patient created a cervical deformity. Then nobody can waltz like this, so the patient tries to bring his eyes parallel to the floor, and he created a scoliosis at the thoracal area. And if you look in the lateral bending films, you may see that this thoracal scoliosis is not a structural scoliosis. So we decided to only operate this patient at the cervical area, and you see that after giving a cervical good alignment, you may correct the thoracal scoliosis here. So, to understand the cervical deformity, we have to know some terms. First of all, cervical lordosis, C2 SVA, C2 C7 SVA, chin-brow vertical angle, T1 slope, and thoracic inlet angle. The cervical lordosis is the angle between C2 and C7. C2 C7 SVA is if you drop a line from C2, and this C2 C7 SVA is the distance between this line to the posterior superior border of the C7. Chin-brow vertical angle is the angle between the chin-brow line and the perpendicular line to the floor. T1 slope is the angle that one line passes over the plateau of T1 and the line passes parallel to the floor. And if you show us on the X-rays, this is the line that passes over T1 and the line parallel to the floor. This is T1 slope, and a line from manubrium sterni to midpoint of T1, and another line perpendicular to the midpoint of T1. This angle gives us the thoracic inlet angle. So, is there a relationship between these angles? You have to say that there is no magic formula like the pelvic incidence and lumbar lordosis. The difference between these two angles plus minus 9 degrees, we don't have a magic formula at the cervical spine. But we know that the thoracic inlet angle determines the T1 slope, and it determines the cervical lordosis. It means that if a patient has a large thoracic inlet angle, the patient needs a larger lordosis, and also a small thoracic inlet patient needs a small cervical lordosis. Again, large thoracic inlet, large lordosis, small thoracic inlet, small lordosis. So, there is a chain of correlation like the pelvic incidence and lumbar lordosis, and there is a correlation between thoracic inlet angle and cervical lordosis. We may say that the sacrum of the cervical spine is T1. And if we apply to the clinical cases, we know that there are some factors for cervical myelopathy, static factors, dynamic factors, vascular factors, and also one of them is kyphosis. So, if we come back for the first case, the patient has neck pain because we couldn't achieve a good cervical lordosis and we couldn't achieve the C2, C7 SVA. And in the second case, again, we couldn't achieve the cervical lordosis and the C2, C7 SVA is still 3 centimeter. In another case that they operated outside has failed, then we operated this patient, we give a good lordosis, and C2, C7 SVA is normal. As I learned from the presentation from Daniel Ryu, if you don't know anything about cervical spine, cervical alignments, only drop a line from the midpoint of the ear to the floor, and this line has to be behind the sternum, and if you can bring it near to the sacrum, you will have good results. Like in this case, we have a good cervical lordosis and we achieve a good C2, C7 SVA. In the conclusion part, the cervical sagittal alignment is important. We have to consider the alignment, and we have to bring the head over pelvis. Thank you so much for your attention.
Okay. May I ask the presenters to come to the floor here and